All right, so considering we're short for time, we'll go relatively fast for this just to move the sessions along. But we'll be talking about acute limb ischemia, and this will kind of be the blueprint for the next few talks. So some more detail will be gone into. So no disclosures, and this is about the classification, the data review, and the algorithm to treat. Some basic stuff, but as we get into the data review and the algorithm to treat, some things that have been changing in the recent years. So acute limb ischemia is defined as a sudden decrease in limb perfusion, which is causing a threat to viability of the limb. And this is in patients who present less than 2 weeks of events. If this has been going on for a prolonged period of time with rest pain or tissue loss, we consider this critical limb ischemia. However, it's really the duration that manifests as acute limb ischemia with rest pain, ulcers, and possibly gangrene. This is a very dangerous condition with mortality rates up to 10 to 15%, leading for amputation. In-hospital mortality can be very high. These patients are often very sick with concomitant coronary disease and cerebral vascular disease. And then these patients also have a high 1-year mortality. So there's a profound physiologic cause and effect, and the severity of the ischemia then dictates the approach. In terms of diagnosis, we've all seen this. It's the 6 Ps, and so it's based off the physical exam with paresthesias. Pain is very real. It's constant, and it increases with touch. Pallor, pulselessness, paralysis, and coolness. Now, when you see these patients, you want to identify their history. How long has this been going on for? That's very important, and we'll get into that a little bit. The location where the the acute limb ischemia is happening, the suddenness of onset, if there's any history of any vascular surgeries in the past, prior endovascular interventions, or symptoms of claudication. So if a patient's been normal and they just present, it may be very different than someone who has a claudicant or a smoker who is presenting. And it's also going to change your algorithm for treatment. In addition, you want to look for other atherosclerotic risk factors, as patients who have chronic vascular disease or chronic coronary disease may have collateral flow that can actually diminish the severity of their symptoms and allow you to have a different prolonged treatment range as opposed to someone who is more of a de novo presentation. Like I said, you want to look at the history, if there's prior bypasses, prior lower extremity interventions, history of arrhythmia, and also aneurysm, whether it's personal or family history. You're going to check the pulse, and be careful because a water hammer pulse can indicate an occlusion. So if you're dealing with arm ischemia and you feel a brachial pulse, but no radial pulse, and you feel and your resident or fellows insist that they have a really strong brachial pulse, that could just be a water hammer, that the blood flow is being stopped there and you're feeling a profound pulse in that area. You also want to look for aneurysms, especially if we're dealing with lower extremity acute limb ischemia. Behind the knee is going to be one area on the physical exam you're going to check, and for the belly, you probably rely on a CAT scan, but this can be the source of embolization or thrombosis. Probably most of the people in the room have seen this, the classic sign of hanging the leg off the side of the bed to relieve pain, using the gravity to increase the pressure, the perfusion pressure to the foot, but we also see the change in color. You can look at that foot and you know that it feels cold just from the picture. We don't have a signal on Doppler, and we can present with, for patients with critical limb ischemia, in addition to this acute limb ischemia, we can have the beginnings of ulcer formation, non-healing wounds, dry gangrene, and this is even things like venous disease in a certain capacity with phlegmasia can cause an acute limb ischemia, which is we won't really discuss in this talk. So we have the classic Rutherford classification. I think the most important thing for this is the difference between 2A, 2B, and 3. 2A is a threatened limb and it's urgent. We have absent arterial pulses, present venous pulses, and there's either no motor loss or mild motor loss and some sensory loss. And you have some time in these situations to start a heparin drip and to evaluate the patient. However, when a patient comes in with 2B, this is a reason for emergent repair, emergent imaging. You have absent arterial signal. You have no, you have some possible motor loss, sensory loss, delayed capillary refill, and we need to go to the operating room or the endovascular suite for revascularization. The thing that's not really talked about that much is class 3, and class 3 is very important to recognize because these patients do not do well with the revascularization, and we'll go into that a little bit later, but you may want to try your hardest to revascularize, but it's going to make the patient worse. Pathophysiology, emboli can be acute on onset. They could be the primary history of the embolism. You have a known embolic source like the heart or an aneurysm. These patients often have no other history like claudication, and they're normal on the contralateral side. So we're going to go a little bit faster. There's thrombotic and embolic possibilities, and this is a distribution of them throughout the body, with lower extremity and aorta iliac being the most common sources for these emboli to lodge. Imaging should not be delayed. When it's going on for longer than 6 to 8 hours, we're going to get neuro and motor deficits. And imaging can be performed with angiography, CTA, a duplex, or even an MRA, but most often it's either physical exam with CTA or duplex imaging. And so here are some pictures of cutoff embolic source in the iliac arteries or below the knee. In this image, CTA, we're going to skip past it, but we'll see on the right side there's going to be a blockage in the iliac arteries. So we scroll down. Actually, it may be the left side. And this is an aneurysm, and aneurysms can also cause embolic changes, embolic phenomenon that can lead to acute limb ischemia. Excuse me. This is aortic dissections can also block flow to the leg. So revascularization with a TVAR or EVAR in certain situations can open up that dissection flap and lead to improved perfusion to the leg. The goal is rapid restoration of arterial flow, limb preservation, and avoidance of complications. So this is a general algorithm for treatment. If we start the patient immediately on heparin, we want to classify them into 2A, 2B, or 3. And if it's 2A, we have some time for imaging, like I said. 2B, we want to get imaging as soon as possible and bring them immediately to the operating room because time is limb. And 3, we want to proceed with maybe an amputation, whether it's immediate or delayed. In terms of treatments, it's really progressed since the 1970s when we just had amputation and heparin to bypasses in the 80s. And I think they were pioneering some stuff during the Korean War. Lytics started in the 90s, and we've kind of moved away from lytics into percutaneous mechanical thrombectomy. Open surgery is always a great option, but it is invasive, and some of the newer technologies now allow us to get away from the knife and have minimally invasive rapid restoration of blood flow. However, for some chronic emboli, it's also, for large emboli, it's often the most expeditious way to get out that clot. Fogarty invented this in 1961, and we still use it today. And here are some exposures that we use to get down to the blood vessel. So in addition to, we spoke about patients with chronic PAD, they may also require endarterectomy for the plaque in the blood vessel or bypass. And concomitant angioplasty and stenting of culprit lesions. For example, if you have a iliac artery lesion and there's a thrombosis of the superficial femoral artery, afterwards you may want to stent that lesion after you remove the clot in the femoral artery. We talked about class 3. The reason that class 3 Rutherford is so dangerous is that the byproducts from ischemia can cause significant morbidity and mortality. So in those patients, again, we want to proceed with amputation. But in other patients after reperfusion, it's a big deal. We can have compartment syndrome. We could have patients becoming dependent on dialysis, either short or long term. So we want to be conscious of those changes after revascularization. And I won't really go into the details of compartment syndrome, but it can be very morbid. The muscle does bulge up, and if you don't treat it, you may have done the best job ever and you revasc, but after this compartment syndrome happens, if you don't treat it, you may still be left with an amputation. So this is ways that we close it, with whether we use this ladder technique or with wound vacs and skin grafts eventually. Here are some other causes of acute limb ischemia, but we'll go past it. And this is some some closure device related causes of acute limb ischemia. This was an angiostele that embolized off after a cardiac intervention in the popliteal artery and needed a cut down. and it's taken out. We could see what the angiostil is taken out. Per close can also cause dissection flaps after closure and cause acute limb ischemia. And oftentimes you'll have to cut down on the vessel. You can have some stenting can be useful, but pretty much in these situations, open repairs are advised with an endarterectomy and maybe after that a concomitant stent to tack down the dissection flap. And so in the last minute that I'll take, we'll talk about catheter-directed thrombolysis. So this has really kind of fallen out of fashion, even though it can be a useful adjunct for percutaneous mechanical thrombectomy. But you want to bathe your thrombus in plasminogen activator, TPA, and give it some time. We've kind of moved away from placing the patients in the ICU for 24 or 48 hours, but that was the kind of the gold standard in the late 2000s. They also have suction catheters like this Craig McNamara catheter. If you have a discrete tibial vessel occlusion, you could suck back the catheter. But we've moved away from this because these patients have bleeding complications. There's a lot of contraindications in order to use lytics, and so we've moved past. This was just showing that lysis versus surgery. Lysis is as efficient as surgery with shorter length of stay, similar amputations-free survival rates, but it is related to, there is some major hemorrhage that can happen, including intracranial hemorrhage. And that's what I was talking about, the limitations of the thrombolytics. The mean duration is usually less than 24 hours, but to get a good result, sometimes they have to be more than 24 hours. And it's really dependent on the plasminogen supply, so it doesn't work well in patients on PA1-rich or platelet-rich clot. And it does induce a systemic lytic state, which can cause hemorrhage and intracranial hemorrhage and death. So, like I said, we've moved to the gold standard of percutaneous mechanical thrombectomy devices like Penumbra, which the surge of the devices happened in the 2000s, and we continue to get innovations in the clot. And so the goal is to remove this clot with aspiration, suction, maceration, and then retrieval. So less thrombolytics are needed, lower ICU time, less complications, and the cost improving nature of it needs to be studied. So this is the export catheter. We have the angiojet, which is combined lytic and mechanical aspiration. But we've now advanced to these Penumbra catheters, and the recent advances in this technology have allowed us to do suction catheter aspiration with a computer-aided software which limits our blood loss for these procedures. This is the Penumbra catheter being used to suck this clot out. And newer technologies that are being developed are these kind of basket-based technologies which combine the percutaneous mechanical thrombectomy with an actual coring element which pulls back the clot. And so we see this with the Pounce or the Artix device from Inari. And so this was a recent study where they take 23,000 patients, and there is a comparable in-hospital limb salvage mortality rates compared to open repair. But there is an increased risk of reintervention, but most reinterventions avoided open surgery, and these patients had, again, decreased length of stay. So in summary, when you're dealing with acute limb ischemia, you want to accurately classify the patient, whether it's Rutherford 2A, 2B, and 3. And then if it's 2A or 2B, you want to get expeditious revascularization with an appropriate modality and be conscientious of the revascularization that can happen afterwards. And so what is best? Nowadays, I think most people are leaning towards percutaneous mechanical thrombectomy. The knife is always an option, but lysis is becoming increasingly niche with maybe just being used as an adjunct. Overall, you want to practice judgment and have your care be related to the individual patient. Avoid irreversible ischemia, act fast, and there's no approved drug that can just be given systemically for the patient, so mechanical devices can speed restoration of flow, and they are becoming more cost effective. Thank you. Sorry for taking more time.